Muy buenos días.
Good morning. I am Mauricio Massa, and I am the regional advisor in the Pan American Health Organization in the initiative against cancer. It is a pleasure to have everyone here. We have this activity that, in order to commemorate World Cancer Day, and in fact, we, over the last few years, were not able to host an activity such as this. We to bring together many of the initiatives that the World Health Organization and other agencies, including the International Agency to Combat Cancer, have been working now for years to ensure that we could work together in cancer prevention and treatment, not only regionally, but also globally. To begin today, we will start off with a short video with a few words of welcome from our director, Dr. Barbosa, who will discuss the commemoration of World Cancer Day. It is a pleasure to be here to host all of you at this World Cancer Day commemoration so that we can close the gaps in treatment. In the Americas, more than 4 million people are diagnosed with cancer every year, which has a major negative impact in families, individuals, and the communities. As we look at the social determinants as well as environmental determinants that have an impact on people's behavior and lifestyles, the Pan American Health Organization, as well as the International Agency on Cancer Research, has developed in 2023 the Latin American and Caribbean Code to combat cancer that looks at public health policies and lifestyles in order to help prevent and treat cancer more effectively. We believe that there needs to be a greater equity in terms of access to treatment and preventive measures in order to strengthen health measures against cancer. PAHO is working with several global initiatives. The Global Initiative for Eliminating Cervical Cancer, for example, has looked at an increase in providing overall coverage in vaccines so that we can reduce the incidence by 70% and have a global coverage at 90% by 2030. The initiative is to at least achieve a 60% increase in survival rates for children suffering from childhood cancer. The initiative focused on reducing also the reduction in carcinoma cases and mortality. So this affect over 74,000 women are affected, and this has the potential for being eliminated in terms of cervical cancer. And so we are focused on eliminating cervical cancer and increasing the vaccination coverage as well as detection and screening, looking at laboratory tests, working with the revolving funds from the PAHO organization. 45,000 children are affected by childhood cancers. The rates vary from country to country. We need to increase monitoring and increasing access. PAHO is working with member states in 28 countries in order to reinforce access to prevention and also treatment for childhood cancer and training thousands of healthcare professionals to improve screening. In the area of breast cancer, PAHO is focused on early detection and screening, increasing quality of mammographies so that there's an increase in early detection of breast cancer. We are working throughout Latin America in order to prioritize detection, screening, and equity in terms of access to healthcare services, hoping to close the gap in cancer treatment so that we can ensure better health outcomes for our patients and citizens. Well, I'd like to thank Director Barbosa for those words of introduction as we commemorate World Cancer Day. Today, we have a webinar, as I mentioned earlier, that we're very excited about. We have It's going to be a session where we have experts, colleagues from the International Agency to Combat Cancer, the World Health Organization, our office in Geneva, as well as representatives from civil societies looking at the diverse initiatives to combat cancer. To begin, we're going to discuss the global initiative for the development of cancer registries so that as we begin this webinar, we have Dr. Marion Piñeros. She is a surgeon, an expert in public health, who is also a scientist working in the Office of Information at the International Cancer Research Agency under the WHO, working with various countries in the region in order to improve coverage and quality of information that we have relating to cancer. So now we will become more familiar with the details of the initiative that is underway. So I'd like to offer the floor to Dr. Marion Piñero. Well, thank you and good afternoon to everyone. I would like to thank Mauricio. I'd like to thank the PAHO organization for this kind invitation as we commemorate World Cancer Day. I hope everyone can see my presentation. So I just wanted to mention that the slides are in English, but I'm going to be speaking in Spanish. So the Global Initiative for Cancer Registry Development, briefly, this is one of the major initiatives that have been launched in Latin America. And as you are aware, IARC is focused on providing surveillance data and recorded data of high quality. We are working basically in these three key programs. The first that you're familiar with are global indicators, where we have the Global Cancer Observatory, we conduct research, and we, of course, work in developing new publications. This would not be possible, though, if we didn't have accurate cancer registry information. Looking at the cancer registries over the last few years, we've seen a major thrust. The data coverage of good quality information for the region has still not achieved that 100% target. In that regard, therefore, we saw the development of the Global Initiative for Cancer Registry Development. Many of our partners headed by our agency. I'm not going to get into all the specific details, but it's important to highlight that there needs to be country leadership, there needs to be a regional focus, and we need to emphasize global coordination. So, the key principles include providing training and providing and incorporating those stakeholders that contribute to developing and launching many of these new initiatives. All of the efforts regarding the use of cancer related information is, of course, going to rely greatly on the accuracy of the registry information. Here we have the GICR model. We've highlighted the different regions in various colors as we see centers of experts from the region highlighted. We have in Colombia, we have the Universidad Javeriana in Bogota. Then we also have the National Cancer Institute in Montevideo, in Rio. So these are the three overarching areas that we focus on within the network, which is training the trainer network. We hope to expand and accelerate support to countries. The driving concept here is that we develop standardized materials so that the various trainers can use the standard data and information. We also have some self learning modules. Then the other component looks at the developing information technology with the adequate software, the CanReg. There's a lot of information technology, and we need these aids to provide us with digital uploaded information. Then we've also placed a lot of emphasis with our partner countries to ensure that we develop specific development plans based on the priorities. Regarding with the training net, these are the key areas that we've been focused on in terms of the cancer registry. We have trainers in every area. This has allowed us to expand our operations, and they're very much involved in the training courses. Currently, we have developed with Vital Strategies and Bloomberg Philanthropies with their support. We're now ready to launch these contents. We are translating the contents into French and Spanish. Hopefully, all of you will soon have this tool handy so that you can use to provide these courses or either the complete course or individual modules. I just wanted to mention this project. This is a Innovate project, cancer module within DHIS2. This is being done basically with working with the Rwanda National Cancer Registry, as well as piloted with Caribbean Initiative as well. These are the partner countries. There's just a few on the slide. We have three partner countries from the region. We have El Salvador, Paraguay, and Mexico, who are signatories to specific agreements as we continue moving forward in these developments. These agreements include regular follow up meetings according to the specific challenges and goals. We meet frequently with the team members. We have expert visits programmed. And we also have mentoring activities, training. I won't get into a lot of detail here, but these are some virtual courses that were hosted during 2022, 2023, where cooperation with PAHO and various agencies, such as, for example, the basic course provided for cancer registry personnel, also working with many stakeholders that have had an active involvement in these forces. This has been a effective way in regionalizing training. Some of these were provided in Portuguese, some in Spanish, not always following the exact same script. Let me just focus now on some of the WHO global cancer initiatives as we commemorate World Cancer Day. And we look at that with the GICR. We have the global strategy to accelerate the elimination of cervical cancer as a public health problem. We cannot measure the effectiveness if we don't have the necessary records and registry. Then we also have the Global Breast Cancer Initiative. looking at early detection goals, and we look at the goal of the global initiative is to achieve at least a 60% early detection. That's our goal. And then finally, then we have the global initiative for childhood cancer. 60% is also a goal that we are seeking to achieve. And we can only do these things if we have the proper registry resources supporting it. Also important to highlight, as you can see here, and these are initiatives working with Silvana at PAHO. We have worked in particular with special emphasis in getting information in the area of we have the CAN staging tool. We also have working with the GICR in eliminating and reducing childhood cancer. And we can see that thanks to GICR and thanks to the registries providing through the PAHO and agencies, we continue to move forward in our goals. That's just to conclude. And I want to thank everyone. And I invite you to review the contents. Last week, we just issued our new information website so that you can review it, review the reports. Thank you very much. Thank you, Marion, for that presentation. And as you've already pointed out, it is so important to know that the efforts that are being undertaken are having a significant and meaningful impact. Without that accurate information and more complete information, it would be difficult to respond. We know the new information that was just shown was again released last week, and you can see the historical development of many of these milestones, and you can see that in many countries, this is having a significant impact in the cancer program. So again, thank you very much, Marion, for joining us. And now, as we continue, now we can look at a practical example of what has already been undertaken. It is a pleasure to be able to talk a little bit about this initiative with Sarah. Sarah Quesnel Crooks.
In the field of public health, focusing on supporting non-communicable diseases in the Caribbean. She's the technical officer for the Chronic Disease and Injury Department in CARFA, the Caribbean Public Health Agency in Trinidad and Tobago, and in 2016 became the program coordinator for the IARC Caribbean Cancer Registry Hub. And she provides technical support to build and strengthen in-country cancer registry capacity. So it's a pleasure to first get the picture from Marion and IARC of the programs, and then actually see how this becomes into practice in real life. And thank you, Sarah, for joining us today and sharing your experience.
Thank you so much, Mauricio, and thank you for the opportunity to share some of the work that we're doing in the Caribbean. So just to give you just some very brief background, but in terms of the cancer burden in the region, a lot of our data to really understand the burden comes from mortality data, which is available for most of our countries. And mortality data, as you know, shows that there's an extremely high burden, and that in the Caribbean, we have the highest burden of deaths from non-communicable diseases, with cancer being the second leading cause of death. So of course, representing, as we know, a significant regional public health threat. When we compare our mortality data in the Caribbean to that we have easily available, which was the US, we found that we were disproportionately affected in certain cancer types. So looking at age standardized mortality rates, for example, from select cancer sites, being the cervix and prostate, that our age standardized mortality rates were up to 9 times higher than that was seen in the US. We do have a very good political or government response to cancer, Caribbean ministries of health have established important frameworks and targets for reducing cancer burden. We had the 2007 Declaration of Port of Spain, which is the first global political commitment that placed focus on reducing both morbidity and mortality from NCDs within the region. Of course, Caribbean countries are WHO member states, and therefore they support the WHO Action Plan on NCDs, the NCD Global Monitoring Framework, and the UN Sustainability Development Goals. And these are also part of the latest phase of the Caribbean Cooperation in Health Initiative, or CCH4, which is a Caribbean initiative that unites the region for improvements in health. And they have very similar targets to those from WHO and the UN goals. Now, despite knowing that we have a very high burden from cancer and that we have the political will to address cancer, we have very limited access, as other low and middle income countries, to reliable, high quality data on cancer incidence and related risk factors. And as you may know, this will, of course, limit the ability to monitor important trends and to really understand the extent of cancer burden. Our ability to allocate resources is reduced. We can't respond appropriately to the burden. And of course, it lacks our ability to monitor progress to these important targets and goals that we've all agreed to. And of course, as you know, the best way to capture the information that we need is through population-based cancer registries. So I'm providing this background information to show why the Caribbean Public Health Agency has joined or has decided to focus its efforts on improving cancer registration in the Caribbean. So it's just a quick picture of what cancer registration looks like in our region. So as you may know, the region consists of several island countries, as well as Belize in Central America and Guyana and Suriname and French Guiana in South America. Some of our Caribbean nations have been successful in collecting and contributing high quality cancer data through national cancer registries. And these, of course, can support their national cancer control and prevention efforts in these countries. This, however, represents coverage of only a small percentage of our population within the Caribbean. And the ability of other countries to operationalize or sustain high quality cancer registries is, of course, limited by limitations in resources. This is both financial and human resources, and of course, competing health priorities. So in 2015, CARPHA worked together with IARC, and CARPHA became the implementing body for the IARC Caribbean Cancer Registry Hub. So as Marian just presented, there are 6 hubs that exist globally in different regions of the world as part of the GICR, the Global Initiative for Cancer Registry Development. And we are the hub that supports the Caribbean. The hub functions are, as Marian presented, these 4 main areas of focus. So we conduct training or capacity building in the form of both basic and advanced courses for cancer registry staff or Ministry of Health staff and other connected stakeholders, and as well as develop important resource materials. We do directed technical support through site visits, and these site visits can assess an existing cancer registry or readiness to implement cancer registry processes, or they can be along the lines of advocacy at high-level ministerial levels to implement cancer registration and identify resources to support cancer registries. We also connect our registries within the region, either to other high-quality registries within the region or experts outside of the region as needed in mentorship arrangements that has worked very well. Networks have been extremely critical. Before we began, our networks within the region, at least, were quite weak in the area of cancer surveillance, and now that has been strengthened significantly. And we do stimulate and conduct research either at CARPHA or in collaboration with a registry to support cancer control efforts. Our Caribbean hub has been successful truly through our ability to attract and maintain critical partnerships. Our partners have been within the region in the identification of high quality cancer registries within the Caribbean that have become centers of expertise. At the moment, we have the Martinique Cancer Registry, and this has been very important. harnessing expertise that already exists and making this available to other cancer registries and ministries of health within the region. But we've also, very importantly, had partnerships that can bring financial and technical resources to the work that we do. This has been, of course, IARC, but also, and PAHO, but also the US National Cancer Institute, the US CDC, Centers for Disease Control and Prevention, and the North American Association of Central Cancer Registries. And these partners have been with us since 2016, and they've provided very critical financial and technical inputs that have truly made our hub successful over the years. I just wanted to quickly just spotlight one of the activities that we're working on at the moment. Marian mentioned that this is part of the Innovate project, which is looking at strengthening IT data collection and collation applications that are used in national cancer registries. And this is important because Jamaica is the second country in the world that will be using the DHIS2 oncology module that was developed by Rwanda for use in Rwanda. And this was recognizing that there were some challenges that Jamaica was experiencing with the existing CANREG 5 software, which some of you may be familiar with, and the need to have data collection from multiple sites across the country with data centralized in a single database. And through a collaboration with the Ministry of Health and Wellness in Jamaica, but also other very key partners, meaning IARC, the University of Oslo, the HISP Center, the University of Oslo, and of course, the Rwanda National Cancer Registry, we are about 3 months into a project which will customize the DHIS2 oncology module that's being used in Rwanda and make this operational at the Jamaica National Cancer Registry. And once this is completed, this would be a module or a tool that we will be making available to any registry that's interested in using it. This work began in September last year, and the project will be completed in December this year, and it's being funded through a Vital Strategies Data for Health Initiative global grant. In terms of some of the activities that we have planned for the next few years, we will continue to support strengthening cancer registration activities within Caribbean countries through advocacy, capacity building, and directed technical support. We continue to stimulate, coordinate, and conduct collaborative research initiatives to support cancer control in the Caribbean. We will support strengthened IT applications for data collection, collation, and reporting. And this is where the Caribbean cancer registries are using CANREG, soon to be CANREG 5+, or the DHIS2 oncology module. And we hope to strengthen regional and international partnerships and networks, including possibly collaborating and working with the Latin America hub in the future. And thank you very much again for the opportunity to share some of this work.
Thank you so much for sharing that experience. We know that, like you said, I mean, having one of the 6 hubs presenting today and from a region has been great to get a sense of what that actually means and how that's translated into practice. And I think, like you said, one of the biggest challenges is the limitations that we have on resources and human resources. So we're so glad to see how you're supporting in all these different areas, and hopefully how we can collaborate in the future to expand those efforts within the sub-region. So thank you again, Sarah, for your intervention today. Y ahora, continuando, vamos a iniciar ahora.
And now we are going to continue with the initiative from the IARC from the WHO, and now we will have our colleagues from the World Health Organization from our office in Geneva, and we're going to begin discussing the different initiatives. The first one will be the global initiative to accelerate cervical cancer. And we are so lucky that we have someone from our region presenting, and it is Dr. Maribel Almonte. Many of us know her for the work she's done for so many years in the research area. Before she went to the WHO, she was working at the International Agency Against Cancer, and now she's an implementation scientist in screening of cervical cancer and supporting the guidelines for screening and diagnosis of this in this initiative. It is a pleasure for me, therefore, to leave you with Dr. Maribel Almonte, who will be presenting on the Global Initiative for Cervical Cancer. Thank you very much, Mauricio. I'm trying to share my screen here. Okay, there we go. Can you see what I'm showing? Yes, yes, thank you. Okay, thank you very much and good afternoon, everybody. It is a pleasure to be able to discuss and talk about this topic, and considering that we are celebrating the World Cancer Day, and be able to uh, convey all the important messages of the initiatives that we have in the World Health Organization around cancer. Many of you know me, and many of you have perhaps heard a part of this talk, but I think it's always interesting to emphasize why we're here and what we intend to do. So, elimination of cervical cancer, according to what we want at the WHO, is to eliminate it as a public health problem, which means that we establish certain thresholds and certain goals to achieve this elimination as a public health problem. As Marion mentioned, we have said that it has to be less than 4 cases of invasive cancer per 100,000 women. And this is age adjusted, and that's our incidence threshold. We have three goals: 90% girls vaccinated with full schedule with the vaccine against HPV up to 15 years of age. The second goal is 70% of women be screened with a high yield test between 35 and 45 years of age, maybe twice in their lives, and that 90% of women who are identified having some kind of cervical disease, either a precancer, precancerous injury lesion, would receive treatment and clinical care which is adequate based on these three pillars. And if we go to the first one, vaccination, to achieve that goal of 90% girls be vaccinated against HPV, we have certain strategies that we have developed. The first one, to ensure sufficient numbers of affordable vaccines against HPV, improve quality and increase coverage of vaccination, improve communication and social mobilization. Communication is very important. Communication to parents, communication to the public in general, communication about the new recommendations that we can issue, and the whole communication and information system to people is what will make a difference and will make our implementation programs be a success. Innovate to increase efficiency in vaccination programs. And in this sense, we are, let's say, we're happy and proud to see that vaccination schedules against HPV have been implemented in most countries in our region in Latin America. And here, let me show you the map until August 2023. Blue color, blue and orange and light blue see the countries that have already implemented vaccination programs. And we have some countries that have already well, they have opted for using one dose of vaccine, and I will tell you more about it later. But I can tell you that this is what we have at this point in time. So if we see coverages, the history is a little different, or the story is a little different, but having vaccination programs which are already included in the EPIs in the countries, it tells us what we have progressed and regarding this first pillar of elimination. Here, This is what has been happening in the Americas. And we see here in this graph how there has been an increase in coverage from 2010 and what we've seen until 2022 post-pandemic. So this is what we can see is that in Latin America, most girls have access to the vaccine at this point in time. And we are reaching about 2 out of 3 of these girls with a first dose at least. And so when we want to, and since 2017, there was a decline in HPV coverage, but we have started to see a few encouraging signs that coverage is improving and recuperating. So we continue to develop plans, implementation plans to improve coverage so that we can reach 90%, which is the goal for elimination. But we're doing well. We could be doing better, but we need to make all our efforts to do even better. The second pillar refers to 70% women being screened with a high yield or high performance test, and at least having 90% of the women with some kind of detected cervical disease detected through screening be adequately treated. For this, we also have certain strategies as promoting the use of simple screening algorithms to be able to increase retention to the complete process and improve efficiency of the programs. Understand all existing barriers. Again, communication, improving communication and information. What is a screening? Why it is important? Why do we need a high performance test? And why HPV vaccines. And it's very important to explain all of this very clearly to the target population, being women, of course, the priority population between 30 and 40 years, but also to the public in general, so that everyone understands why we're doing this, to ensure affordable supply of tests for screening and treatment equipment, which are all of good quality and high performance. We need to try to achieve both quality and also a supply that is affordable for most women in the target population, reinforce capacity of laboratories and screening programs and services, and integrate screening services and treatment service and into programs of primary health care. We need to uh, be more efficient in using the resources which are usually limited. Now, when we think in terms of screening and talking about the algorithms that need to be simple, the latest guidelines that were issued back in 2021 emphasized the fact that we needed to use 2 types of schedules: screening to treat, and then screening, and then do a second test for triage to select a population which is at a higher risk of developing disease, and then treating those who are positive, both on the first test and the second test. Also, we recommend that in principle, we should try to use the HPV testing on the DNA, both is a self-test or the ones collected at the health post. In orange, we see what we have resolved and added for 2022, and some is published and some is about to be published. The use of HPV mRNA testing only in tests recollected by healthcare providers. In some cases, we don't have all the research, so we need to obtain all the evidence before we can fully recommend. So also we can have a partial genotyping for HPV 16/18, colposcopy, IVAA, and pap smears, and pap smear with dual dye, P16 Ki67 only samples collected by the healthcare providers and for treatment for ablation after verifying eligibility with reference of non-eligibles. With an asterisk, screening and treating or using mRNA testing or using the triage dying are not recommended for HPV positive women because there was not enough evidence so far. And here, the next step is to think that there are many technologies that are being produced and are accumulating evidence. So we need a faster, more agile method, which allows decision makers, if whether they can stop doing something which is already obsolete or continue doing something they're doing. Some things are obsolete. They are just a waste of resources. Maybe they could go to something else. And so we have a process that started last year, and it is called a living systematic review. We are evaluating new alternatives to give more options to the countries when they are going to implement their programs. This is a complex slide, but I wanted to emphasize that these are the priorities we are evaluating right now. And this year, we are going to start with extended genotyping, which includes other high risk types or carcinogenic types for tests that give us not only an individual result for HPV 16, 18, but others that are also high risk so that we can know what the next action is. We're also evaluating the self-testing. We are improving certain protocols. We want to monitor evidence for women with HIV, and also we are aware of, for example, new technologies, the use of AI for a cervical test. And among these key points that we're studying, we decided to start with development of the profiles for the target products. In other words, so that companies can have new products developed. And since we are setting up the minimum requirements and the preferences that we want the new products to have, this way, those who develop technology and other products can take into account our needs, and so that what they produce have a high level value for public health. And we're still working on this. There will be a web page so that people can go, and those who are interested can leave their feedback. This will be happening soon, perhaps Wednesday or Tuesday or Wednesday of next week, and we will try to disseminate information as soon as we can before final publication is ready. It's also important to emphasize that in these profiles, we have included characteristics for new tests that can be used with the person who's being screened to obtain immediate results based on an HPV PV test and be able to refer them to triage or treatment. Regarding the third pillar, where our goal is to have 90% women identified with cervical disease being treated and receiving adequate clinical care, we need to reinforce access and availability of histologic diagnosis and appropriate and adequate treatment, ensure adopting clinical management guidelines. Not all countries have them, and we need to work together to achieve this, also optimizing human resources in order to increase coverage. We are able to reach our goal, reduce the stigma due to cancer by means of reinforcing again education, information, communication, so that people know what it means to have cancer, what are the treatment options and the steps to follow. Also provide integral comprehensive care to survivors and prioritize palliative care as a human right of every person. To sum up, let me tell you that in order to achieve elimination of cervical cancer as a public health problem, we need to uh, advance in the three pillars by 2030, reinforce vaccination programs, maintaining 90% coverage, and plan monitoring actions as well as impact measurement. It's also important to have that we are starting to know what our objective is within 5 years, within 10 years, and what is the impact of what we are doing for implementation of vaccine campaigns. It is necessary to introduce simple algorithm in our region. We've always used pap smears, followed by biopsy, followed by treatment, then colposcopy. This hasn't worked the way we wanted it to work. So it's important to introduce simple algorithms or algorithms that are more adequate to the realities of each country and with each scenario within a country, considering technological innovation, which offers us opportunities to accelerate elimination. And this is why we have the living guidelines to rapidly evaluate technology and give new options that are cost effective and make the process more expedite. We need to concentrate implementation on strategic investments and coordinated actions by multiple interested entities. We have several agencies and we have PAHO and WHO supporting. We need to continue to update all the different protocols for validation and ensure that there is a sufficient supply of vaccines, screening tests, and teams to be able to provide treatment. And we need to reinforce also the work of laboratories and screening teams. Thank you. Thank you very much, Maribel. It is very important to see all the tools that exist at present, but also know that new technologies are being developed and it's great to learn about these profiles. We're going to have a webinar specifically to present the results of the study Estampa. This was a study led by Maribel with other researchers from the region, and we hope this will be our next webinar for cervical cancer. So again, thank you very much, Maribel, for your presentation. Now, we will give the floor to our next speaker. We have a colleague who has been with us in many of our regional meetings, and she will be making a presentation on the work done in Chile for many years and how they are beginning to transition with this initiative. We have Gina Medino from Chile. She's part uh, of the Ministry of Health, focusing and working on cancer matters. And Gina is going to share her experience regarding elimination of cervical cancer. Thank you very much, and thank you, PAHO. I'm glad we are here together in the commemoration of the World Cancer Day. Let me share my screen now with you. I'm representing the Ministry of Health of Chile, and this is work developed by many professionals who have uh, working from different divisions. So it's a collaboration, and it is my privilege to present it. Today, I'm going to talk about if you're not familiar with the general characteristics of Chile, I will start with that, our context, our social and health related matters, and I will also talk about the international framework, how we are doing assessment based on the pillars that were presented. I'm going to talk about epidemiology. I'm going to discuss the pillars. And Chile, we are a thin and long country in the southern portion of Latin America. It has more than 4,000 kilometers in length, so it is the longest country in the world. 16 regions, 56 provinces, 346 municipalities. Our population was 19 million inhabitants. 50.7% of them were women. Out of this group of women, about 3.3 million are women from 30 to 64 years of age. In Chile, we have a population structure which is urban, living in the urban population about 89%, and 80 years is the life expectancy. The structure of the health sector is as follows. We have three sectors: public, private, and the armed forces. Public sector is 83% of the population, and it is about 16 million people. So within this international framework that was mentioned before, we have the global initiative to eliminate cervical cancer. And in the year 2020, we had this initiative started. And so member countries have been urged to start programs which are evidence-based and incorporate them in their health systems in order to achieve the universal coverage by vaccine. We have three goals: 90, 70, 90. And it is the immunization pillar, the screening pillar, and the 90% final 90%, which is treatment for women who have been identified with cervical disease. Epidemiology, here we have 11 per 100,000 women with this disease. In 2023, 1,618 women were diagnosed with invasive cancer, and there were more than 13,000 women with pre-invasive lesions. Survival by 5 years is over 58%, and their mortality rate adjusted by age was 4.5 per 100,000 women. This is translated to this. In the year 2022, we had 629 deaths due to this cause. Cervical cancer also is one of the main diseases in Chile, which affects within the age group of women who are still in a productive part of their lives. So it is a very important disease in public health, and in particular in Chile, due to the figures I have shown to you. Now we're going to analyze the following: how we are progressing regarding each one of our pillars. And I will begin with pillar number 1, which is reaching 90% of immunization in girls. In the year 1978, we created the National Immunization Program, and in 2014, the VPH vaccine, HPV, excuse me, HPV vaccine was included. The tetravalent and for girls 9 and 10 years of age. The catch-up was the year 2015 and 2023. In the year 2019, vaccination was extended to boys. In the year 2024, we will have a new non-valent vaccine against HPV. And so this is a great progress in this area. In this first pillar, we vaccinate girls at 9 and 10 years of age, the first dose at 9, in girls and boys has achieved 88%, and the second dose, we have 79% in both girls and boys. And thanks to the global initiative, girls before 15 years of age have achieved 81.6% rate. We still have a gap before we achieve the 90% goal, but we hope we will achieve it by the year 2030, as is the goal.
Pillar 2, which deals with screening. Legislation 19.966 from 2004 established a regulatory framework in order to increase access, timeliness, and quality, as well as financial support for this screening. In 2004, again, these guarantees established by law that developed a regulatory framework, strengthening again the timeliness, quality, and financial resources from screening all the way up through follow-ups, including palliative care. So this has been ensured through the regulatory framework for those between 25 and 64 years of age to have a pap smear every 3 years with a update with timeliness of 30 days. Up through since 2019, we've incorporated progressively the HVP tests to genotyping, individualized genotyping, as well as group genotyping. And also wanted to mention that currently we have a way of measuring the cervical uterine screening through HVP testing. The coverage achieved by 2023 a coverage of 54.3%. In 2024, locally and progressively, and as a result of the healthcare reforms underway, we are also going to incorporate HVP testing in a complementary manner that includes a self-applied testing by the users. And then we look at Pillar 3, dealing with treatments. Within the legislation that we mentioned that established a regulatory framework for access and screening, we look at, that includes treatment. For us, it's easy to measure this because it is now from the very beginning, starting with the screening, diagnosis, we're able to follow the complete path and track it. So just to very briefly comment that for the pre-invasive treatment, we have, for example, low-grade and high-grade lesions. For low-grade lesions, we have a time frame up through 180 days since the initial indicating. And then we have, because of this, for these interventions, the low-grade invasiveness, we have a 97.9% coverage. In those high-grade lesions, we establish a maximum time frame of 30 days from initial indicating. 96.9% is the coverage there. And for those treatments of invasive lesions, we establish a 20-day time frame. And here we have a lower compliance, which is about 84.6%. So these percentages mean that people now have access to treatments, but they, again, do this within the timeframes of compliance. And this, again, is an internal challenge. So just to conclude, I just wanted to mention that Chile has a lengthy track record in addressing cervical cancer. And over the last 5 years, I have led the process. I've coordinated efforts with the various divisions in the Ministry of Health, working with the ministry for some time now. These efforts, joint efforts, have allowed us to successfully reduce mortality rates, 5 per 100,000 women, thanks to public policies that emphasize preventive measures, early detection, and as a result, we have the potential to become a country that will completely eliminate cervical cancer, but it's also going to depend on the definition of the standards and follow through, as we mentioned in the earlier presentations, because the incidence is again, we're looking at reducing by 70% the incident. And obviously, we need to keep up and maintain these measures. And hopefully, we will achieve the goals established for 2030 or before 2030, increasing access to treatment, ensuring timely interventions, and through screening. We have, in this group, we have recommended to maintain the levels of immunization and treatment and prioritize the incorporation of screening. So thank you very much. Thank you, Gina, for sharing with us that excellent experience that Chile has in the area. And as you've highlighted, and I think it's essential for many countries to understand that this is a marathon. There are many years of work that have culminated in these results. And with sound regulatory measures, when we see the levels of high levels of treatment, we would hope that many other countries could achieve these same milestones, including increased coverage in immunization. We know that screening is a major challenge for countries, even countries that have been doing this for a long time. We know that the pandemic has had a major impact on coverage levels. I think we're making up for that lost time, but in this transition, we need to see exactly how this is going to have an impact in other areas dealing with women and getting these results. So thank you very much for sharing your experiences. I know it's many years culminating in this, and we want to continue to follow your progress. And hopefully in the near future, we will achieve many of the goals that were just described.
Now we're gonna shift from cervical cancer to the global initiative, the global initiative for breast cancer. And for this, I'm very happy to have a good friend who is the technical lead for cervical cancer at WHO headquarters. Not many probably know, but in his former life, Andre he still is a cancer surgeon and worked in various countries, practicing, and now he's leading all these wonderful initiatives. We're really happy to have him with us today and to present with the region specifically to talk, in this case, the Global Breast Cancer Initiative. Thank you, Andrea, for your time. We really appreciate that you're here, and happy to hear about the newest initiative from WHO.
Thank you so much, Dr. Maza, Mauricio, indeed a dear friend and a leader in the community. It really is our privilege to be here with you and to speak to the PAHO community. You may know, but in many ways, we turn to the PAHO community in the cancer agenda because you are often leading the way in country implementation and country impact. So it's a great privilege to be able to join you, to share with you some of the perspectives in the early phase of the Global Breast Cancer Initiative, and also strategize where can we take this initiative together through a community-driven approach. In the next 10 minutes, I'll focus on these 3 elements in the new chapter of global breast cancer control since GBCI, or the Global Breast Cancer Initiative, was launched in 2021. First, the power of data. Second, the power of action. And finally, the power of implementation. As you know, breast cancer is among the most commonly diagnosed cancer globally, now ranking number 2 with the recent release of the IARC estimates, and number 1 in women, affecting about 2.3 million women each year. Outcomes from breast cancer vary significantly between countries and even within countries. When we look at the estimates on progress in reducing breast cancer-specific mortality, many countries are unable to reach the general target of a 1/3 reduction in premature mortality, in line with SDG target 3.4. And even within countries, here we have data from the European region, but we can see that there is a profound inequity within countries relating to cancer, and specifically in breast cancer, where 1 in 6 cancer deaths can be explained by educational differences alone. So let's then take a deeper dive into cancer inequalities. In order to do that, we looked at this first order question. Are governments including essential breast cancer services in their health benefit package as part of universal health coverage? In the Americas, for basic breast cancer surgery, we can see coverage is very positive. Every country surveyed in the region includes coverage for mastectomy. But when we start looking at other essential or priority services, the numbers begin to drop. When we looked at the inclusion of the essential medicine trastuzumab that has now been in the market for 25 years, we see that the number decreases to 2/3. When we look at also important services like breast reconstruction, if a woman is to lose her breast as part of treatment for breast cancer, less than half the countries in the region offer treatment for that breast to be reconstructed. And in the unfortunate situation that the woman dies or needs psychosocial support, again, fewer than half the countries in the region will cover those essential services. And because of these inequalities, we began to see the unmet social impact of breast cancer. More than 60% of women who are diagnosed with breast cancer experience anxiety or depression. There are more than 2 million children who have lost a parent to breast cancer. 30% of women affected by cancer and their caregivers never return to work after a cancer diagnosis. Financial hardship is affecting as high as 70% of women and their families in low and middle income countries. And of course, we can imagine the impact on GDP and major economic losses. So what is the consequence of the difference in health system readiness to control breast cancer? And we can see that there are 2 very different trends. In Western Europe, USA, and Canada, breast cancer mortality rates have decreased 2% per year or higher. In contrast, breast cancer mortality in Latin America has been stagnant and in some situations increasing. So at WHO, we took a step back and evaluated what explains the different trends in reducing breast cancer mortality. The factors that we interrogated included aspects like access to medicines, screening programs, national cancer control plans. We found 2 interesting key findings. First, the primary drivers of reducing breast cancer mortality was whether or not the coverage of the percent covered by universal health care in the country is high. The second factor is the density of public cancer centers, not private cancer centers, but public cancer centers. It was also important to note in this study that all countries that reduced mortality were also able to reach a threshold of 60% early stage breast cancer. And this could be achieved even in the absence of a screening program. So these were the factors that informed the foundation of the Global Breast Cancer Initiative, these 3 pillars, as we will explain shortly. So let's take a step back then and learn more about the power of action in GBCI. The fundamental objective and target of the Global Breast Cancer Initiative is to reduce breast cancer mortality by 2% per year. Doing so will avert 2.5 million deaths from breast cancer by 2040. Maybe I'll say that again. 2.5 million women can be saved from breast cancer if we are able to fully implement the 3-pillar approach of the Global Breast Cancer Initiative. This is not just an aspiration, it has been done and it can be done for countries around the world. So let's better understand what is that 3-pillar approach from patient care and looking across the entire pathway, acknowledging the importance of community engagement and multi-sectoral participation. If we start with the first pillar, it focuses on health promotion for early detection. The overall target is to improve early presentation to the health sector, and doing so in a way that allows for early stage breast cancer to become commonplace, again, reaching a target of 60% breast cancer stage 1 and stage 2. The second pillar is the process from initial contact with the health sector that includes the diagnosis and staging and workup, and that entire process should happen in 60 days or less. The third pillar, it is that all aspects of multidisciplinary cancer care through multi-modality services, that is surgery, systemic therapy, and radiotherapy, are offered through an interdisciplinary approach, inclusive of supportive and palliative care, and that 80% or more women are able to complete their full treatment plan without abandonment. So then how can these three pillars help operationalize a breast cancer program as part of an integrated approach to cancer control at the country level? In order to understand that operationalization, we will look at how the three pillars are translated into implementable strategies. This indeed are the details of how governments can take up GBCI and PAHO member states can see impact by reducing breast cancer mortality. The three key implementation approaches that we'll focus on: first, again, universal health coverage; second, looking at workforce optimization and access to essential medicines; and finally, adhering to the principles of person-centered cancer care. Here's a sample approach of how WHO and PAHO are supporting the inclusion of breast cancer as part of cancer control planning and also as part of universal health coverage. It is done through a data-driven approach to health planning. We start by assessing current health system capacity to deliver cancer services and to better understand feasible scale-up scenarios. We then give recommendations on how to scale up and reach higher coverage and better access. And finally, we can offer a business model or a business case for how investing in breast cancer programs can avert deaths, how costs can be saved, economic costs can be averted, and what is the return on that investment. Here's an example of the prioritization that we did in one country that had a very common challenge of late-stage disease. The government was interested in looking at a screening program and at an early diagnosis program. As you can see, an early diagnosis strategy was more feasible, less expensive, and could avert a similar impact of overall lives saved in the short term. This major decision then shifted the government approach to focus on early diagnosis and then in due time take up a breast cancer screening program through, again, a data-driven decision-making process. The second key element to successful implementation of GBCI is to recognize the importance of acting now, investing in capacity building and helping governments get fully to scale. In many countries in the PAHO region, we know that the breast cancer will nearly double by 2050, doubling of the breast cancer burden. What does that mean? As we can see, it would require a doubling of infrastructure, number of hospital beds, number of cancer hospitals, number of providers, etc. Doing so requires a major investment today to be ready to absorb the burden of disease. And since 70% of breast cancer cases cannot be prevented, many governments must start planning now to absorb that increased investment and the increase in capacity required to deliver services. Similarly, we are seeing this as a major threat to cancer control, but the workforce is under great stress. From oncology providers, primary care providers, nurses, pharmacists, social workers, and others, there is increased burnout now after the pandemic, and the burden on the oncology workforce will only grow with time. And finally, I won't go too much into detail today because of time, but a lot more can be said on access to health technologies. Essential medicines and breast cancer and technologies we know will have a rapid impact on health budgets because of costs associated with an increased number of people receiving care and also the increasing cost of medicine and technologies. Again, WHO, PAHO partners stand ready to support in each of these areas, but the capacity building needs to start today to deal with the doubling of the cancer burden that we expected. And finally, we can only succeed in the breast cancer agenda if we remain focused on women who are experiencing hardship after a cancer diagnosis. WHO, also working with PAHO and others, we've launched a campaign to amplify the voice of people affected by cancer and using a community-driven, person-centered approach like paid family leave and protection from discrimination against workforce employers and against discrimination from insurers. It is through a community-based, person-centered approach that we will in fact see the change and the advocacy required for that change to happen in the short term. So to conclude, cancer and breast cancer in particular is a critically important development and health priority, particularly in the current time of health budget strains and health systems under duress. WHO and PAHO, we're working with more than 75 governments that have signed up now to be part of the different cancer initiatives with significantly increased interest in the breast cancer program. But for us to succeed, we must do so together, aligning our work, and that is part of a regional leadership structure that PAHO is overseeing. Success can only come if we remember inequalities between and within countries. Families are being pushed into poverty. There's a generational effect of a breast cancer diagnosis, and this cannot continue. One of the crises that we must also acknowledge is the crisis in the workforce and the effect that cancer is having on both families, communities, and the oncology providers trying to offer the services that they need. As we've heard so well, the last point is the importance of data. Dr. Piñeros has said this so well, but for us to succeed, we must also invest in data systems. If we measure, we can succeed, and if we succeed, we can go to scale globally. So together we will move forward. Thank you for your time and attention, and we look forward to implementing this initiative together. Thank you, Dr. Maza, back to you.
Thank you. Thank you so much for that great presentation and highlighting, how this disease has inequalities and the social impact behind it. But it's wonderful that as you presented, all these data-driven policies are being developed. I think something that really marked me was that you expressed how the workforce is under great stress and how capacity building and coordination with other organizations need to happen, because none of these initiatives are really going to happen if we don't work together with different organizations, UN agencies, civil society. So thank you so much for highlighting all of this. And we're really looking forward that in 2024, we start more implementation efforts around this initiative. Thank you so much. And, thank you, Dre. And talking about collaborations, I'm very excited to present our next two panelists that are gonna collaborate on this presentation around something that's around the first pillar and working between the first and the second pillar. For that, we have Dr. Kaiva Medlin, who works at PAHO at the radiological health and focuses on improving radiology services in health areas through imaging. Her background is in radiology technology, and she provides tools to ensure the quality of services. And one of her great collaborators, institutions, which is MD Anderson, we have Dr. Toma Omofoye, who is an associate professor of radiology and the director of breast imaging and global oncology cancers network at MD Anderson. I'm so happy to have you both. It's been a great pleasure of all the work that that's happening. It's very exciting, and looking forward to see how we disseminate what has started in the Caribbean region and hopefully extend beyond. So thank you so much for being here.
Thank you. Thank you so much, Mauricio. It's really been an honor to work with you within the past year and a half, and of course, an honor to work with MD Anderson. So I am going to start my presentation. So the title is Addressing Breast Imaging Quality in the Caribbean. Of course, we will also cover MD Anderson and PAHO collaboration. So my first slide just has a lot of numbers, and I'll let you go over them. But I do want to point out two things. That because data is so fragmented, those numbers could increase, and that early detection through mammography does improve outcome and treatment option. So, as our colleague in the WHO mentioned, imaging is part of one of the pillars, and the target is really to detect breast cancer stage 1, stage 2 in 60% of any given population. So the question becomes, how do we do that? Do we just purchase equipment? No. Quite frankly, imaging is not photography. There needs to be procedures and guidelines implemented in order to constantly produce quality images and optimize radiation dose. So for a quality assurance program, we need to have best practices in regards to the human component, meaning that the radiographer needs to be well trained to produce quality image, and we do rely on the radiologist's interpretive skills. When it comes to the equipment, this is again not photography. This is a very complex equipment, so it does need to go through regular maintenance and quality control tests. Because if it doesn't, the quality of the image will diminish and radiation output will increase. So it's very important for the medical physicists to do their job. It's like our cars. We make sure it's maintained and well taken care of. So does this equipment. There's also a non-technical component, workflow. Here's an example. A patient comes in January for a mammogram, doesn't get the results till October or November. It takes 6 months for the woman to see changes within her breast. So what was once stage 1 could easily become stage 3, stage 4 within that time frame. So I'll give you a few examples of what we are talking about when we are mentioning quality. So this projection is called medial lateral oblique. In the middle there, we put the 8 criteria of what constitute a quality image. If you look at the pectoralis muscle, it does not extend to the level of the nipple, which indicate that the entire breast is not included in this image. Now, we're not going to talk about sharpness or contrast because it's here in this image. As you see, the pectoralis muscle extends to the level of the nipple. That's where you see this white little dot. The image is sharp and very clear. So the radiologist is perfectly capable of interpreting this image. We'll get back to the medial lateral oblique of the first image that I mentioned in my previous slide. And as you see, it was repeated. So within this red box, that part is the breast that was missing from the first medial lateral oblique. And with that, this is cancer that was missed due to poor positioning. And that often occurs when there's poor training on the part of the radiographer, and sometimes even the radiologist, because they need to be able to determine whether or not this image is of quality. So this patient goes in a facility for a mammogram. The mammographer uses a computed radiography in a cassette that is for extremities instead of a cassette dedicated for mammography. The wrong technique was used for this, poor exposure and poor positioning. So this is not an image of quality and it's not of diagnostic use. So the image that you're seeing to your right is a phantom that the medical physicist uses in mammography. What I circled in yellow are small dots that simulate calcifications. The round items that you see simulate mass. So when the medical physicist does their test, all of this needs to be visualized. And on top, you see some specks. So if they're not visualized, that means that when the patient comes in for their mammogram, they won't see calcifications and they won't see the mass. And that is very worrisome. So the image that you see to your left is an ultrasound of a mass. This patient was wrongly referred. She had actually breast pain and a mass, but she was referred as a screening instead of a diagnostic. So when she went to get her mammogram, the radiologist called her back It took her around 5 months to return. Once the ultrasound was done, it was clear that this is very concerning, and she went in for a surgical biopsy. It was actually an invasive and in situ ductal carcinoma. So all of this speak to the importance of implementing appropriate guidelines and protocol to reduce medical errors and not just purchasing the equipment. So this is my last slide. I wanted to leave you with this. To your left, you will see this image. What I circled are what we call calcifications. Calcifications are those little dots, the white grain of salt. They could be benign. In this case, it's an invasive ductal carcinoma, so it could also be malignant. Please look at the image to your right. Can you see calcifications? Can you see a mass? So that is the importance of image quality, because if you aim to offer these services, please ensure that you will be able to detect breast cancer at its earliest, most treatable stage. Because if you don't, it leads to a lot of medical errors, but it will also lead to suffering from the patient, her family, the community, and an increased financial cost. Thank you so much. I will hand the microphone to my esteemed colleague from MD Anderson, Dr. Toma Omofoye.
Thank you for having me. Thank you for the invitation. And it is enlightening to see so many of these presentations echo similar themes. I'm speaking primarily about the MD Anderson collaboration with PAHO. MD Anderson Cancer Center in Houston, Texas, certainly shares the vision of making cancer history and working to help with cancer control globally. While MD Anderson has been a longtime ally of PAHO, today I'm going to speak about some of the work we have done with regards to breast imaging. Our goal in this collaboration has been to improve image quality through monitoring quality improvement, capacity building to train the radiologists, technologists, medical physicists to improve patient and staff safety, and to also improve the diagnostic performance of all the staff. Next, please. In this collaboration, we are able to perform sub-regional breast imaging training seminars, monthly virtual echo sessions, as well as in-country breast imaging seminars. Next slide, please. Beginning with one of our earlier collaborations, MD Anderson and PAHO collaborated on a sub-regional seminar titled Improving Mammogram Image Quality. The objective was to provide didactic and hands-on training on image quality for the Caribbean, and this was hosted at University of Miami, November of 2022. For this program, we had 27 attendees from 10 Caribbean countries, and you can see the breakdown of the professional roles that were represented. Next slide, please. As part of that training seminar, we provided a post-seminar evaluation. In addition to the participants indicating that they had overwhelmingly received benefit from participating in the seminar, when asked, what areas of practice will you change as a result of attending this course? You can see that the participants all included, or the vast majority included, that quality improvement was something that they would change in their practice going forward. But you also see other ripple effects of other practice areas that are impacted when we emphasize image quality in mammography. Next slide, please. Similarly, PAHO and MD Anderson collaborate on in-country workshops. And here I just wanted to highlight a recent workshop performed in Trinidad and Tobago, in this case to perform didactic and hands-on mammogram and ultrasound image quality training, as well as biopsy practice. Through this program, we collaborated with the in-country leaders, in-country practitioners, as well as partnering with professional societies for radiographers and technologists for the Americas and internationally. This seminar received support by the American College of Radiology, who donated a phantom for quality control testing for the country, as well as the Society of Breast Imaging, which donated BI-RADS atlases to the radiologists to help improve the interpretation of mammography. The hope, of course, is to improve early detection of breast cancer so that we can see benefits in decreasing mortality of breast cancer. Next slide, please. One of the other collaborations I want to highlight between PAHO and MD Anderson is a Project ECHO collaboration. For those who may be unfamiliar, ECHO, which stands for the Extension for Community Healthcare Outcomes, is a program through which we perform knowledge sharing in a network of community and academic clinicians who communicate by Zoom on a regular basis, sharing case-based examples of clinical challenges and receiving suggestions for possible solutions. In this format, we're able to promote interprofessional relationships for telementoring of the providers in low resource areas by providers in academic medical centers. Next slide, please. Project ECHO has many demonstrated benefits. For patients, they're able to receive the right care that's evidence-based, standard of care at their home, in their local area, from providers who have been able to acquire more knowledge, empowered to treat more patients, and building a community of practice. There are also benefits to community and system that's been documented through the use of Project ECHO, including the ability to reduce disparities and keep patients local. Next slide, please. For PAHO and MD Anderson's Project ECHO collaboration, which is named MIMIC, MIMIC stands for Mammography Improvement in the Caribbean, we conduct a monthly virtual meeting of the allied providers in radiology, so the technologists, radiologists, medical physicists, and allied disciplines, wherein the providers in the Caribbean can share challenging cases and receive didactic instruction as well as suggestions on the possible solution to the case of interest. And together they build a community through this regular meeting that helps over time to improve capacity building and access to state-of-the-art practice. Next slide, please. Through MIMIC ECHO, we performed an evaluation of impact, and we're able to demonstrate significant attendance through majority of the English-speaking Caribbean. But even beyond that, we have regular attendees to this session who are based in places as far as Ethiopia, India, and Saudi Arabia. So the need for education, continuing education, and access to real-time feedback from specialists is something that we found to be very welcome by practitioners in the Caribbean. Next slide, please. Fortunately, MD Anderson and PAHO continue to have this good formal collaboration through which we're impacting multiple cancer systems. But the next steps for the breast cancer collaboration is continued evaluation of the MIMIC ECHO, which represents a certain standard for curricula, in that curricula have to undergo continuous updating and response to current needs. We also plan an upcoming sub-regional conference with IAEA that will be hosted at MD Anderson in May 2024. And this, of course, echoes what we've heard from other expert panelists today, the importance of collaborating with like-minded societies and professionals across the world if we hope to truly impact any of our cancer control goals. Next slide, please. Of course, it would be impossible to accomplish much of anything without many, many contributors. So thank you very much to PAHO, to the teams highlighted on the slide, but really to everyone whose work in cancer control helps to move us towards global health equity. Thank you.
Thank you. Thank you so much to both of you. This has been a wonderful collaboration. And as you expressed the need of continuing education that's required not only within our region, but by seeing how even countries of outside the region are joining now, the mimic sessions showcase the need for that. And how do we disseminate, importantly, the newest initiative from WHO to ensure that not only the clinical uh, uh, personnel that are part of this, but also from a programmatic side, so we can ensure that we can hit those three pillars with the disease that's has the highest burden in women in our region is something that we really need to collaborate more and expand the work that we're currently doing. So thank you so much for sharing this great experience and collaboration, and looking forward to more work to come. Thank you. Ahora vamos a continuar con el tema
Now
del
we're going to continue on, and we will have the last initiative. And this one comes directly from the World Health Organization. We have the pleasure to have among us Dr. Roberta Ortiz. She is a pediatric oncologist from Nicaragua. In 2020, she started working with the team, and we've had the privilege today of having a large number of members of this group, and she's the coordinator of the Global Initiative for Childhood Cancer. Dr. Ortiz, has been a great support not only in our region, but in all regions. And over 70 countries participate in this initiative. It is a great pleasure to introduce Dr. Ortiz to talk more about the initiative of pediatric cancer. Thank you very much, Mauricio, for your kind introduction. Let me see if I can share my screen. I also would like to thank the team, our team of friends from PAHO, for this opportunity to share with you today the results of this initiative, about 75 countries. And it is a great motive of pride to be able to work throughout the 6 regions of WHO, but with the colleagues, the parents, the patients who allow for this initiative to be a reality. And we are also happy that we are able to work in this. So WHO launched this childhood cancer initiative. We are going to talk about the cure-all framework that has helped strengthening cancer treatment for children and helping prioritize children's cancer in national policies. In 5 years, WHO, working with the different countries, is complying with the mandate issued by the World Health Assembly. So, of why children cancer, this type of cancer, as well as other non-communicable diseases, is a very significant disease in our society. When we review the statistics given to us by the different statistics worldwide, by the WHO and other surveys, we realize that children's cancer is not included in national health programs. So about only 42% include children's cancer, and in lower income countries, fewer children still have access to quality treatment. So that's why there is such a gap between children diagnosed with cancer in a low income country versus a high income country. children's cancer is a human right, is a matter of equity, is a matter of social justice. And it also provides the countries and the governments with the opportunity to make advances in cancer control and in controlling non-communicable diseases in general. When you are contributing to improving cancer statistics, you are contributing to improving the overall health in that country. So, based on this premise, based on what I've just said, the World Health Organization, together with one of the main implementing partners, which is the GICC, they launched this initiative, as you will know, in order to increase survival of children's cancer at least by 60%, to bridge the inequity gap. Then we need to do things by increasing the country's capacity to provide quality service to children with cancer, increasing prioritization of children's cancer, both globally, nationally, and locally. After this initiative was launched, it was possible to have the implementation through the framework, and thanks to the commitment of many partners through a multi-sectoral collaboration, including over 200 partners nowadays, but also through regional implementation models, including networks and practice communities and networks. You may be familiar with the Cure-All framework, which is the worldwide initiative of WHO. And so we see how we are aligned with the basic components of health systems. And then it has been able to lead to justified action, which encourages countries to develop priority actions to strengthen cancer services and helping increase access to quality care for children, and also including children's cancer within national health plans and programs. And now let me share with you very quickly here an overview of the implementation of the Cure-All framework in the past 5 years around the world in the 6 regions. And we have 75 countries that are actively participating in implementing the Cure-All framework. So if we review each one of the pillars of this Cure-All framework, we begin with the pillar 1, centers of excellence. We see that significant progress has been achieved in the different regions, strengthening children's cancer systems, and reference and counter-reference systems have also been strengthened to timely diagnose children. This is a significant thing so that children may have higher chances at survival, but also implementing models that are adapted to the national context. And we have very good examples in in the region of the Southeast Asia, and Myanmar and Nepal, and also, as has been mentioned here, it's important to invest in capacity training and invest in health human resources through training programs and other education efforts. And here in the Americas, you have excellent models and resources that are available on PAHO's virtual campus. So to continue on to the second pillar, it is about the universal health coverage initiative. We have many examples in the world, including children's cancer in essential health packages. This has been a very important example of the worldwide initiative because through new legislation that has been enacted, children's cancer has been included in essential health care packages. In our Central American sub-region, we have El Salvador and other countries in the African region, as in Ghana, Zimbabwe, and in the Pacific West in the Philippines. And we also have complied with objective number 2 of the initiative, which is advancing on prioritization of children's cancer in national programs and policies. So thanks to the implementation of this initiative, children's cancer is being elevated to the highest levels of government. So now there are health plans and programs that include children cancer, and they have support by IARC and other international agencies, and helping do prioritization exercises as explained by Andre. In order to comply with the first objective of providing quality care to all children with cancer, regardless of where they are born, we need to have standardization in managing care, and this is being achieved around the 6 regions through the development of treatment guidelines or standards to manage the 6 index cancers. They are not the only cancers, but they are the first index cancers that were selected to be the most prevalent and the ones that have high survival rates. And so they can be the tracers of progress. Of progress through the Cure All initiative. And you see here how these are the countries that are advancing in standardization of children cancer treatment. And pillar number 4 is represented by evaluation and monitoring. And of course, our colleagues have already explained the importance of surveillance of cancer registries to have information that allows countries to formulate their own national policies and be able to confront the heavy burden of children cancer. And at the WHO, we have developed technical documents, some of which are still in process, to be able to identify some of those indicators which are essential to measure progress. Last year, we received a new mandate from our member countries to develop a global cancer report, which is being prepared right now. This report will be able to document advancement of the 3 initiatives that we have shared with you, and we will be offering more information about this because this will be done through a consultative process with the countries. As you know, talking about Cure All, we also talked about the 4 pillars, but in order to implement these 4 pillars, we need the support of the facilitators represented by all. ALL related to A is for advocacy, to generate political will to advance the implementation. Then we also have L for leveraged financing. There needs to be continuous dialogue with the different actors and stakeholders for leveraging funding, and also we need to prevent impoverishment of the families. And the last facilitator, the other L, stands for linked policies and governance. It has to do with national cancer plans that are prepared and with the support of WHO and the implementing partners who have developed a series of tools helping the countries to develop their own national cancer plans which are well informed and have what they need to succeed. In this last 5 years, the worldwide initiative against children cancer has achieved the following in the last 5 years. This initiative has advanced, and we see the checklist of each one of those interventions that are included in the operative paragraphs of Resolution 7012. Progress has been made in children's cancer, and we can see the progress around the world. Over 70 countries have received intensive support, not only in technical support, but also financial support. Over 150 centers have been helped to strengthen their capacity to provide care for children with cancer. And in the excellence centers, over 35,000 children have been served since the initiative was launched. As I shared before as well, one of the milestones in progress is a collaboration with St. Jude's from Memphis, and this has been a success. And a new initiative for collaboration was launched, and it was the platform to have access to essential medicines for children's cancer. It is a unique collaboration whose purpose is to guarantee uninterrupted supply of essential medicines for treating children cancer to benefit over 50 countries from 2021 to 2027. As you will know, the problem of stockouts in many of the centers in our region, it prevents children from achieving survival, which is our goal for children's cancer. So this new collaboration offers a unique opportunity, taking advantage of the success of implementing the cure-all framework. So it is not only donation of high quality medicines, but the platform provides technical advice to strengthen what has already been achieved through the Cure-All initiative. And we all working together on this platform, we will continue to help many children and families who still suffer from inequalities in healthcare. As I said before, thanks to the collaboration with St. Jude's Hospital, it is expected that around 120,000 children be helped from lower income countries until 2027. Let me conclude by saying that since 2021, post-COVID, initially the initiative could not make much progress while we still were in the pandemic. But post-COVID, we have seen great progress in the commitment in prioritizing children cancer worldwide, and I've been able to see the six regions make progress since 2021, starting with 15 countries, and right now we have 41 focal countries and 75 countries in all to continue advancing in cancer prevention and treatment. And this has been possible thanks to the collaboration of many partners that are here present. And we've seen how we have an opportunity to advance to universal health coverage, and also in the 2030 agenda through the Global Initiative for Childhood Cancer. Thank you very much for sharing your perspective. It is the first of the three initiatives, but we know that this is not possible without our partners. St. Jude's has been an excellent partner, key. We have other organizations like Childhood Cancer International, Sick Kids in the region. We have CEOP, and we have so many organizations that make this possible, as well as civil society in the different countries. They have led efforts in this sense. And now having the commitment of the governments to be able to take it to a further level through the Cure All initiative and the other collaboration initiative with St. Jude's to increase access to medicines, essential medicines, is something that will make us as a region to meet the goal of increased survival of children for treating children with cancer. Thank you very much once again for being with us. Now, to discuss a national case, we have Karina Quintero, Dr. Karina Quintero, who is an oncologist, a pediatric oncologist, and she is from the Jose Renan Esquivel Hospital, and she coordinates the Cancer Committee for Children and Adolescents. Dr. Quintero, you have the floor.
Muchas gracias. ¿Me escuchan bien? Sí. Gracias, Mauricio. Bueno, vamos a hablar un poquito acerca de lo que es lo que hemos avanzado en Panamá en cuanto a cáncer en niños y adolescentes.
We're going to discuss the progress that we have made in Panama in addressing childhood cancer. We're going to look at the profile in childhood and adolescent cancer in Panama. About 0.6% of all the cases of childhood cancer in adolescents in Latin America. However, it's 0.7% of mortality. That's why it's important to be able to for us, it's important to be able to just share with you all of the progress that has been made, especially in the area of our planning efforts in addressing childhood and adolescent cancer. 92% of essential medicines provided by established by the WHO for treatment of cancer for children and adolescents we have in our response. Here we see in this slide how we have been able to compile specific data from our National Cancer Institute. This is broken down by age ranges. Most of the cases, about 150, a majority of the cases are between the ages of 0 and 14. However, there's also a high percentage between those between 15 and 19 years of age. Looking at the cancer mortality rates, for us, the number one cause of mortality in all children between 5 and 19 years of age is, well, first of all, let's look at the timeline that we have in terms of the launching of the Global Cancer Initiative in 2018. As Roberto mentioned in the earlier presentation, we launched the initiative that year. And for our country, it was also important to include this within the national plan for cancer prevention and treatment. When we looked at introducing a chapter covering childhood and adolescent cancer, the strategy was a significant inclusion in the plan, and it highlights the 4 priorities in the area of childhood cancer treatment and prevention. It's through all of the objectives, the cure-all objectives established in 2021. Based on that, we've been able to make significant progress in terms of cancer diagnoses, training of primary healthcare providers. And in addition to that, we have been able to provide guidelines for nursing staff that address the needs of cancer patients. Also, looking at the development of specific courses, campaigns, and the registry that we talked about at the beginning of this webinar, highlighting the importance of cancer registries, and in this case, a registry that focuses on childhood and adolescent cancer. So the National Strategic Plan for Cancer Prevention recognizes, dating back to 2019, the main mission of the Childhood and Adolescent Cancer Commission, where we see the focus on timely diagnosis. As Roberta pointed out, we've addressed, again, early diagnosis as well as primary health support. We also have a new piece of legislation on advocating for universal coverage of childhood and adolescent cancer, in addition to treatment guidelines and cancer records and registry. And we see in this slide what is the early detection and timely intervention in cases, suspected cases of childhood and adolescent cancer. These are the key pillars that were developed in 2021, and we clearly define the national statistics in childhood and adolescent cancer rates in Panama and other countries, looking at the most common forms of cancer, as well as the evaluation of the potential for cancer in children and adolescents, according to these strategies, as again outlined by WHO. So a new law was passed that includes guidelines for the healthcare staff treating childhood and adolescent cancer. This links back with the legislation for universal health care coverage, which is being worked on right now. As was mentioned in the webinar, we pediatricians are also focused on expanding the immunization programs that includes preventive measures than childhood and adolescent cancers. We can help to also prevent adult disease, as we have interventions with childhood and adolescent cancer. In 2008, we began with the HVP vaccines in children, now covering all ages from 10 years on. We've achieved by 2021 a 72% coverage. And we again recovered after the pandemic to higher levels. Here we see some specific results regarding the initiative itself, the global initiative for childhood cancer. The progress in Panama shows how in the years since the early childhood cancer detection was launched, we've been able to reduce the number of late-stage cancer patients. And this is something that we're trying to expand so that we can provide earlier detection and diagnosis in children, reduce the need for greater hospitalization, and increase the potential for survival of these cancers. With St. Jude, we developed a strategy, a profile strategy that encompasses a comprehensive evaluation of pediatric services. This evaluation was conducted between 2023 and 2024. We've seen 5 institutions participating in Panama City, Santiago, and the strategy, as we see here, that as a country, we have many challenges. We have multiple needs and priorities that we need to address. Some of the most significant ones include integrating services, radiotherapy, as well as registries so that we can strengthen the results that we are gleaning throughout the journey of our global cancer strategies. Therefore, now to conclude, I'd like to thank everyone who has fully participated in the process. That includes the Ministry of Health of Panama, PAHO, CSS of Panama, the St. Jude's Children's Research Hospital, Children's Hospital of Colorado. We want to thank all of you for giving us the opportunity to. Thank you, Mauricio, for allowing me to speak on this subject. Well, excellent, and I want to congratulate you, especially giving us an overview as to how the various pillars in the the pillars of these initiatives that includes early detection, diagnosis, increasing the registry of cancer, and again, early detection. All of these efforts have just been spectacular, and I thank you very much for sharing your experiences and sharing them with the colleagues from throughout the region. And our final initiative that we're going to cover has to do with the Latin American and Caribbean Code to Combat Cancer. This is a joint initiative between the various cancer research agencies from the WHO, and it's a pleasure to have with us Eduardo Catzap, who is chair of FLACON, a former president of UICC, and he's going to discuss the perspective from civil society and the importance of this code for all of us, how this can be disseminated. And you're also going to see how several of these initiatives are aligned to the recommendations with this code. So it's really a pleasure to have Dr. Gassan. Thank you, Mauricio. And I'd like to thank PAHO and its leadership for giving us an opportunity over the next few minutes to share with you the Latin American and Caribbean Code against cancer. Now, my understanding is that this is one of the key initiatives in the Latin American region. Up until recently, the only code to combat cancer was the European Code, which was a tool, it is a tool, to disseminate prevention, especially in the general patient population. And also, it's a tool that fosters greater cooperation among the various agencies. Now, although contrary to the European Code, this is the first code in another region developed with the same methodologies used by IARC in order to develop the European Code. I'd like to thank Dr. Carolina Espina for preparing the presentation contents. I'd like to thank IARC for their leadership and for their funding, as well as Amigo H from Brazil for providing resources as well, in addition to PAHO, that has been an enormous help. Also, ALIC for their support. I'm going to try to just highlight the key fundamentals that are associated with a code. In principle, a code is for healthy people. The code is guided by modern criteria to provide more medical related information in public policy formulation. Now, of course, in case of people who get sick, then you have the other tools that include early cancer diagnosis and interventions, throughout the life cycle of the patient that also include those lists of people who were cured. This is based on the most up-to-date scientific information with reliable sources, very concise, and with language that has been adapted by our communities, and it defines priority actions for the region based on a multi-sectoral approach with expert contributions. This is a collaborative effort that also reflects the consensus of those involved. This places the individual at the center. It's not the physicians, it's not tools, it's not organizations. The code is for the healthy and also sick persons and their families to provide a message as to what are the tools that currently exist that have already been verified by scientific knowledge for primary and secondary cancer prevention. So the code, as we mentioned here, is where, again, it's public centered. Now, of course, it does have a special chapter for health advocates and professionals, public policy, public health systems, and also it's also aligned so that each country, each region will have their own cancer codes. The methodology is in summary, is a top-down strategy with evaluations of scientific evidence, a review of the scientific literature throughout the Americas. There are also groups of experts who evaluated the contents. There were test messages and the pilot projects, and in November of 2023, the Latin American and Caribbean Code Against Cancer was formally approved. The groups that have been working on this are, again, related to the lifestyles. Environmental risks is another section. Also, medical interventions that includes screening, as well as communication and education to provide universal messages for the Latin American region. And we hope that this will influence long-term government health policies.
I'm going to summarize the next part. We've had a secretariat and we had the groups that I have mentioned, and also participation of ALIC, ALIIC, which are the cancer leagues of Latin America. One of the weaknesses in the European Code is that the groups of patients had not participated in their development, and so this led to less communication in the European Code. Here in Latin America, the patients have participated from the beginning, and this has been possible thanks to 60 experts, and there was representation from 13 countries, and it was parity between men and women. And we had participation from the Caribbean, but since there are many small countries and they are in close relationship through PAHO and the Healthy Caribbean Commission. And also there was representation from Central and South America. So we have also the American Cancer Society and Brazil agencies worked on the budget. These are the 17 recommendations grouped per type of recommendation. Of course, we're not going to read them all, but they are all available. We have different groups. and includes environmental factors, internal factors, etc. But then we have the code ready, and it is available in the WHO website as well as on the IARC webpage and the PAHO webpage, and you can have it in the four languages: Spanish, Portuguese, French, and English. In 2024 and 2025, we will be continuing with communications through different meetings, but there is also a regional strategy by Rislaco, and so members from the most of the countries in the region are getting together, and the implementation strategy will be up to each country, and each country will then call on the government and civil society to do a launching of the Latin American code for the countries in our region, and it will be sometime in the spring. It's also important to mention that we also include communications through the virtual campus, and the code is available there. And before concluding, I want to say that this collaboration work started in 2016. However, we lost 2 years during the pandemic. And then after the pandemic, we had to go back and restart some of the things. But this collaboration has been a concrete example, providing a final document for cancer prevention in our region. And it has been a collaborative effort among the agencies, IARC, PAHO, regional agencies who have worked together in a coordinated and effective manner toward actions whose main objective is to decrease cancer and increase the likelihood of cancer control and improve survival in our region of the Americas. Thank you very much. And thank you all the partners for their invaluable help. Thank you all. Thank you, Eduardo, for sharing with us this code, which is so important. As you have mentioned and discussed, we are just starting the work, and we are just beginning and wondering how we're going to disseminate the recommendations, which are not only for the population, but also recommendations for policies in public health for the countries of the Americas. It is a great tool to be able to work in prevention and control of cancer in our region. Again, thank you so much for all that you've done. And are we ready, or we are ready to work in the coming years for dissemination? And with this, I would like to give Silvana Luciani the floor. Silvana Luciani has been working on many of these initiatives from the beginning of her tenure, and let us give her the floor for final words. Thank you, Mauricio. Thank you all very much. This is the end of our webinar. 2.5 hours with many people who are still connected, and it's been very exciting to hear all the presentations and the different participation by international partners and agencies. This is a critical moment to be able to have more impact on cancer prevention and control in our region. With all the global initiatives that have been mentioned, these global initiatives bring more collaboration, more expertise, more agencies, more partners. And we've seen with the initiative of strengthening cancer registries, we have more information, more updated information. We have the Global Can updated data. It's the work that you in the countries and your own cancer registries are doing with the support of IARC to strengthen registries. Also, we have a wonderful strategy to eliminate cervical cancer. We have all the knowledge we require to eliminate this cancer, and the countries are beginning to implement the strategies of vaccination against HPV and screening treatment. And so we are well on our way to eliminate cervical cancer. Now, regarding breast cancer, it's a little more complex because of the different requirements for health services, especially taking into consideration the different qualities of mammograms. With the new initiative on breast cancer, there is the possibility to reduce this cancer. We've been trying to increase access to treatment, improve the quality of mammograms, but without the collaboration of others and without this global initiative that gives us realistic goals, I think we will be able to reduce mortality in shorter times. And finally, for cancers in children and adolescents, so the initiative is new, although already 5 years old, but with the new initiative, with the platform to increase access to cancer medicines for boys and girls, we will hopefully be able to increase survival. And finally, cancer prevention and promotion of healthy lifestyles. We have developed all the recommendations through the code that Eduardo just presented. We know that there are enormous challenges. We need to strengthen health services to increase availability and access to prevention and control cancer centers, but we see that interventions are being implemented, initiatives, examples from Chile, Panama, the Caribbean. So we can see there's progress. Yes, there's a great deal of collaboration going on, and we are here. PAHO is here together with WHO and IARC, St. Jude's Hospital, Anderson. There are many partners helping to implement these initiatives, and I hope this webinar has given you the motivation to continue to implement a new initiative in your countries. And let me end by thanking all the presenters, all of you, Roberta, Karina, Eduardo, many presenters, Thomas, all of you for sharing your expertise. And not only the people, but the collaboration that we have from PAHO with all the different agencies and institutions, CARFA, IARC, WHO, MD Anderson, St. Jude's, etc. We are here to improve implementation of new initiatives. And finally, I would like to thank the interpreters. It's great to be able to have these seminars in the languages of the region. And I would like to thank all the colleagues from PAHO for having promoted this webinar. And this has been a success commemorating World Cancer Day. And I would like to thank Mauricio for an excellent moderation job and on his very special day. So happy birthday to you. Thank you. Thank you. This has been the best birthday present for me. I wanted to see whether we could all turn on our cameras so that we can take a picture. Again, thank you all for your work and all the work behind the screens. All the people, over 400 people have attended this webinar today. and they've been here for over 2 hours, 2.5 hours, here being with all of us. It's a celebration, and for me, it is great that it coincided with my birthday, so I am elated. So thank you very much to all who are here today, and thank you. We hope this year we continue to do extension, to do dissemination, and continue the great work in the region and with the colleagues from all international agencies. It's good to learn what is happening in other regions of the world as well. I don't know who is going to be the official photographer. I can do it.
Sí, sí.
We have a few Aranza Mechi, others. I don't see